Well, just want to start off by thanking the Better Medicare Alliance for having me here. Really excited to be back here and doing things in person again. And really excited for this conversation with you, Zahoor. This morning we're going to be talking about innovation in Medicare Advantage, which I know you have a lot of thoughts about given your work at Health at Scale. I guess just for people who may not know, can you, walk me through sort of your work?
Yes, thank you for having me here. So, we've heard people talk about the right treatment with the right provider at the right time. That's not innovation. What we're focused on is innovation that is data-driven. So what we're focused on is that we know now it's the age of data. We can hyper-personalize every decision, every patient, every provider that's out there. What we've done is we've taken a good chunk of about 150 million Americans over a good 7 to 10 years, understood their journey through healthcare, and with that, we've understood each provider in the country, type of patients they've seen, understood the journeys of these 150 million. Based on that, we have phenotyped each member that comes to us, as well as the provider, and we do three things with that. We create a match for you with the optimal provider for you in your geographical area. Per our data, more than half of Americans are not seeing the optimal provider for them in their area. That's one, and it's based on outcomes, who would be the right provider for me. Secondarily, what we do is we look for under the radar, rising risk folks who do not know that they need help, and they're coming up with an event that could lead them into adverse outcomes. And then lastly, we focused on reduction of low value care.
Yeah, definitely. This sort of innovation is going to become, more and more important as Medicare Advantage becomes more and more popular. What do you think is sort of the path forward for Medicare Advantage, and what do you think needs to change going forward?
So Medicare Advantage is sitting on an incredible opportunity. And I was discussing this with our team, you're the superheroine or the superhero of the future. And it does come with its risks, right? So you're sitting on data. You have the ability to take care of those 28 million, each one of them individually, becoming 32 million, by each individual, by each decision. So the opportunity for Medicare Advantage really is to say, yes, we've got this responsibility. We will have all 28 million patients back, and we will be watching for best decisions. So that's what's coming for Medicare Advantage, along with, the extra scrutiny that comes with it, but you are sitting ideally on a lot of data that can propel you forward in taking care of each patient with each decision.
Definitely. So I just wanted to, talk a little bit about value-based care. A lot of it's been made of it. It's one of the most talked about things in healthcare, I feel like. What's your take on that, and, why do you think it hasn't reached its potential yet?
So, we think of value-based care really in four dimensions, and maybe you've thought about it this way, and I know BB has done a lot of things. So here's the four dimensions of value-based care: high value, low value, zero value, and negative value. There are four dimensions to care. There are many more within that, but you have to think of care in those. Now, how do you arrive at high, low, zero, negative? You have to understand the member, you have to understand the provider, and you have to understand the site of service. So there's always a matrix here. If you do not put all of those things together, you cannot reach a judgment point on what type of care is being rendered or about to be rendered. That's where we're headed as a country, where we need to head as a country, and where it'll be demanded of us both from the government as well as your membership to say, what does this mean to me?
Yeah. So just in terms of the four, different levels of value of care, how far away do you think we are from being able to, to achieve that and sort of suss that out?
So, with what we do, that's how we look at it. There is more data coming in, and we believe it is available. For each one of us, it is available. And the choice of provider is extremely important because she or he makes that determination. But we're here. I believe we're here. So what has happened is there's been a lot of technological advances with AI, data ingestion, machine learning. Cloud computing has created a lot of power that you can do this in real time. which is we're all impatient. We want that decision in real time. So all of that is available. We feel that we're almost 85, 90% of the way there, and more data coming in will improve this. And I'm not saying by any means that this is a one and done. You know, what is high, low, zero, and negative is an ongoing piece, but we're there to be able to make that decision for all 28 million at that point in time.
Okay. And you mentioned AI, you know, one of the, you know, bigger, you know, one of the things with the more potential in healthcare in terms of transforming it. What do you think are sort of, you know, some of the biggest challenges and also opportunities right now for AI and machine learning and Medicare Advantage?
So I know we're talking about healthcare and medicine, so maybe the analogy I'd first give is going to be about the team and the person who's doing machine learning for you or doing the data piece. So, you know, you've got the best cardiologist, maybe it was Mark, maybe it was, who's available to you. Do you want that cardiologist to work on your back? Anyone here want the best heart surgeon to work on their back? No. It's the same thing with machine learning, and we see that. So the education in machine learning is very specific, and we believe you have to hire the right folks who understand machine learning. Then after that, they have to understand healthcare. Then they have to understand healthcare data. They have to understand edge cases, whether the edge cases is an edge or it should be included. There's a lot of clinical nuance that goes in. So it's not just then machine learning and understand data. It is a clinical knowledge, someone who supervises that. So my first piece that I'd put out that the challenge will remain, and by the way, the country is short of machine learning talent in all verticals. It is short. It is extremely short in healthcare. So if we need to do this right, AI machine learning for healthcare apply right, we have to get the right folks reaching the right aha moments on the data. So that's number one. The data is available. Is the data noisy and messy? Of course it is. But that's what a good data scientist really does, is understands and denoises it.
Yeah, so you mentioned just, you know, not having enough people being able to do the machine learning in healthcare. You know, how do we get there? How do we get to that point? I know it's a tough question.
It's hard. You know, I'm blessed to have a team that a third of our team are PhDs in machine learning, and they keep us on our toes. And we did just a quick analysis of the top PhD programs that were granting machine learning PhDs. There are about 20 coming out every year, 20, right? And about 3 or 4 of them come into healthcare, and 3 of them go back into academia. 1 comes into healthcare, right? So it's a matter of how do you bring more of those up, and we're seeing that with some of those programs. We do bring folks in who are smart bachelors and masters, and we teach them, but there is no easy fix here, Ben. It's just that it is, machine learning is complicated, healthcare is uber complicated. You mix the two, you really need the right mindset and stuff, and look at it carefully.
Yeah. So I guess just, you know, sort of taking a step back, how do you think that, you know, AI can start making more of a difference? Is it just the, you know, is it you know, the human talent plus the data issue? What do you think is, you know?
So I think it's an augmentation feature, right? So we're all going to be asked to do more with less. Every provider is being asked to do more with less. They're inundated with data, and so really in the ideal world, and some of the folks on the panel here talked about it, is to put out that recommendation. The decision is still, we're not into making any healthcare decision. It's still the physician that you are meeting, but it's really bringing all of that data to bear and, you know, bringing that data-driven decision so that you're making the optimal decision based on data finally curated. That's where AI and machine learning is leading us towards.
Okay. And so it sounds like you think we have, you know, close to, you know, enough data mostly, generally, in AI, you know, do we need more of it? Is more always helpful, or is it just to add noise?
More is helpful in some instances. So if I were to kind of cast out the data net, so claims are rich with data. There's a lot of clinical nuance in there. You know a patient, you know the meds they're on. They might be on 3 meds. You know the milligram of the meds. You know when they were changed, which provider changed them. So there's a lot of wealth in there. And the good models are ready to ingest additional data. So what is additional data? You can now also start getting lab data. It'll start coming in. You'll start getting physician. So all of that would just enrich it. But at the base, the model has to be ready and the team has to be ready to ingest that and come up with something that's better.
Definitely, that makes sense. Just in, the healthcare industry has often, struggled to, sometimes it's been a little bit behind other industries in terms of innovation. I guess where would you assess, where the industry is as a whole in terms of readiness and willingness to be, adopting innovation? And
so I think the willingness is absolutely there, and there has been a lot of innovation that has been happening. It's just been happening, in a lot of silent ways, and we've had a lot of improvement. I believe that this focus that's coming from the outside on, and I know someone, we're talking about cost. Cost is the focus because it's 25% of the economy, but underneath it, the industry has started focusing on outcomes. So that is happening both at an ACO level and going to the provider level. That focus is coming back up, and it's forcing those who kind of have their hands on the data to push. So I'd say they are energized about it, and they are doing innovation. That's just that it's small innovation. Is it going to have a huge impact overnight? No, but we have to go at it in an incremental fashion.
Definitely. What do you think you're most excited about, just looking into the future of healthcare?
We're from a company that's data driven, so the excitement is more data, and I think the excitement for the Medicare Advantage plans is you have data on your members, and if I were to go back into being uber on top of what's going on, it's the 5th of October. You closed out September for your members. Do you know where each one of them stands? Each one of them, right? That's what I'm excited about. And that's what I know you folks will get to eventually, right? Do you know where they stand? Meaning, by each one of those 28 million who has gaps, who has a contraindicated RX, who has an error in their meds, who needs to see a different cardiologist because they're likely headed towards heart failure, that you should know by the 3rd or 5th day of the closeout of the month. That's what I'm really excited about, that when we as a community here start looking at that as we are the caretaker of these 28 million and we've got the data, and now we've closed out the month of September, here's what's left, and with that will come a to-do. It's not just where they stand, a to-do, so that on the 4th of October you're starting your to-dos to close those. That's where I feel it's headed.
Just to shift gears a little bit, I have to be, I'm a reporter, I have to ask this question. There's been some concern about, fraud and overbilling and Medicare Advantage. Do you think that tech could be, a way to kind of assuage some of these concerns, or do you think there's some ways that it could potentially, exacerbate these concerns?
So it goes to how you create the tech. So our answer is yes. There is a lot of low value, zero value, negative value care being rendered. Nothing new. Everyone knows that. We believe now with the advent of technology, it can be looked at in real time. And in real time, the advantage of looking at it in real time is to call it out in real time and then also have someone else a human look at it, that if this was an edge case or not. But the technology is really there today to look at it in real time. It's not rules driven, because anything that's rules driven gets bogged down into rules, and then there are ways to go outside the rules. So yes, the technology is there, and I think that's what we should use to kind of reduce. And there's both. There is care being not rendered, and there's care being over rendered. So you've got to cover both in terms of disparities and all those things.
Definitely. I guess just from a policy perspective, whether that's just, mindset or, actual policy, is there something that you're looking for more from policymakers just in terms of Medicare Advantage?
So I'm not a policy person, and I'll say something that might become very, very hard to do because I'm going to drive it based on data. But, to me, sitting outside the beltway, we think that policy follows what's already been done that's good and right. So my wish would be that the Medicare Advantage plans get into this mindset of taking care of the member, measuring them, and knowing where they stand at every month end or quarter end, right? So rather than react to stars, many, many months after the year ends, you've got to be on top. So I don't know if that's where policy is going to head. What I would say is my wish would be that the MA plans already start doing that to be ready for policy that might come and say where you stand. That's how I would kind of give you my data / what I think might happen with policy coming down the road.
Okay. And I know you're a big fan of transparency and Medicare Advantage. I guess tell me a little bit more about that.
So transparency is a great thing, right? And personally, as I look at it, and we look at it as a company, there are some areas of transparency that are very easy and very obvious. So you've got drug pricing, you've got disruptors coming in who are pricing drugs cheaper, and you've got a $4 or a $4.50 drug, and you know which pharmacy to go to pick it up. That's exceptionally good transparency. When you start digging in deeper, and we're talking about what does the member, what does the citizen want in transparency, I think we have to be very careful how we're training them to think about transparency. And here's what I mean. So you're going in for a knee replacement. What does the member who looks at a knee replacement price of $15,000 or $17,000, what do they really get out of that transparency? To me, number one, that is not the cost of a knee replacement. 15 or 17 is not. That's a D-Day cost, right? What happens in the ensuing 364 days after that knee replacement? There is PT, there is coming back for an infection, there is a fall. Many, many other things happen, and what we're saying is this is a great start, but it's not done. And so as you get into some of the more complicated, if you may, healthcare scenarios where folks are looking at that, we as an industry have to push back and say this transparency actually is not doing much. I can understand a $4 versus a $5 pill, but when you start saying here's what the surgery costs, it's not real transparency because there is a ensuing at least 364 days after that event. So I think we will have to kind of push and talk more about transparency and what it really means. And we talked about, talking with a few folks here, is it, I know these are seniors, but is it quality of life that gets impacted? Even if you're working part-time, can you not attend work? So those are the things that today transparency is not putting out for the member or patient to ingest as they look at prices.
Yeah, so I guess, why do you think that's not happening, and, what do you think are sort of the biggest challenges going forward for, just achieving this sort of real level of transparency that you're looking for?
I think it's because it's just getting started.
Yeah.
It's just getting started, and it will come to that when we've gone through and folks start looking at that, and then they say, it was not 15,000 or 17,000, so then it'll come in, and again, this is going to be a plug towards data and machine learning is, you do have to predict, you're right? So we've got the power right now with data to say, but this is what is the overall cost of this procedure you're going in. It's not just the day one cost here. So some of those will get developed, and I am very confident that that's what will happen as we go deeper into transparency.
Okay, that's exciting. I guess, is there anything that you're most proud of in terms of the work that you've done so far, and just looking forward?
When we set out as a company and we were creating our use cases and looking at data, one of the things that we decided was we were never going to look at cost. We decided never to look at rates, never to look at costs as we looked at the data. So we got the team, clinicians and the data scientists, to focus on just outcomes. So we started looking at outcomes, and at a high level, there are some very measurable outcomes. Emergency room visits is a bad outcome. Hospitalization, planned, unplanned, is a bad outcome. Comorbidity. So we started looking at that. So what we're proud of as we're working with our team, our mission remains to look at outcomes, and then we like to bring it down to the each Jane Doe, John Doe. That's what we wake up to do, and that's what we're really pushing out for our clients.
Yeah, definitely. Well, it's an exciting time, in this industry and Medicare Advantage. So, really great conversation. Thanks so much for making time today to sit down with me.
Okay, thank you.
Thanks.